award is given to the faculty member who's been voted by residents as one devoted to education this year. It's an annual tradition. So I'd like to talk a little bit about this attending who received the award this year, and it was kind of a close race. So this attending basically is not afraid to tell you that your notes are terrible. They're not afraid to tell you that you missed something on the pacing exam. And they're also not afraid to keep you after 6:30 to go over a list of cases. And they're supposed to be interesting, and it's basically the entire clinic. So this year, the award will go to Dr. Weinstein, who's not here today. So somebody just text her. Thank you. Okay, so next is going to be our second set of research presentations. We have 4 more seniors coming up. They're shorter presentations, but it'll be similar format. It'll be about 10 minutes of presentation, a few minutes afterward for any questions. Feel free to ask questions at the very end, however, please. So our next presenter is Tanya Padilla-Conde, and she will be talking about sequential bilateral cataract surgery on back-to-back days, a retrospective analysis of postoperative outcomes.
All right, hello everyone. It's nice to see everyone. I'm also from South Dakota, so shout out to the fellow South Dakotans in the room. Oh, let me get my PowerPoint up. So it's my pleasure to be presenting my research on close sequential bilateral cataract surgery in back-to-back days, a retrospective analysis of post-operative outcomes. I have no financial disclosures. And as we all know, cataracts are a bilateral synchronous disease affecting millions of people every year worldwide. It is the leading cause of treatable blindness worldwide. And the current traditional treatment is delayed sequential bilateral cataract surgery. And this is when patient comes in, they get their first eye done, then they can wait weeks, months, even years to get their second eye done. And this can lead to lots of postoperative visits, lots of routine visits in between eyes, a lot of travel back and forth for patients. Some patients have significant anisymmetropia. Some patients, depending on what their visual acuity is in their phakic eye, can have poor vision that affects their ability to perform daily ADLs. So another form of treatment is immediate sequential bilateral cataract surgery, which has grown in popularity over time, especially during the COVID era. And this is when patients come in and get both eyes done the same day, the same surgery. And a lot of people who are not really catching on to this type of treatment have 2 main concerns. The first concern is, well, what about the refractive outcomes? And number 2, what about the safety profile? So does using the refractive outcomes of the first eye to guide the IOL selection of the second eye actually improve refractive outcomes? Well, there have been several studies on this. One in particular done by Jabor and colleagues, and another by Landers and colleagues actually refuted this assertion. They said that the surgeons who made adjustments to their selection for the second eye did not actually translate into improved outcomes. And these concerns have been mostly negated because of the improvement in modern era of intraocular lens calculations. Studies have shown that optimizing the ocular surface, using the latest optical biometers, applying validation criteria, and using the latest generation formulas such as the BERT2 are useful for enhancing refractive outcomes. So what about the risk of bilateral postoperative endophthalmitis? Well, again, several studies have been done to look at this. One in particular looked at a series of 95,606 ISBCA surgeries, and there was no case of bilateral endophthalmitis. A different study looked at this as well and showed that the overall infection rate was 0.006%. Another study looked at the theoretical risk of simultaneous bilateral postoperative endophthalmitis. That's with proper aseptic technique and intracameral antibiotics. And it showed that the estimated risk was 1 in 100 million. So overall, very low. So in summary, studies have shown that ISBCS performed no worse than DSBCS for postoperative best-corrected visual acuity, refractive error, or complications. So why does my study matter? Well, to my knowledge, this is the first study looking at close sequential bilateral cataract surgery on back-to-back days. And we hypothesized that this could allow for a reduction in intraoral wait time. It would prioritize patient convenience while still having good visual outcomes and have a similar safety profile. So the study design, this was a retrospective multi-center chart review of patients who underwent cataract surgery in back-to-back days from August to September 2020. There were 3 different locations at a private practice, Van Thompson Vision, in Omaha, Nebraska, Bozeman, Montana, and Fargo, North Dakota. Our primary outcome was visual acuity, both corrected and uncorrected, compared to the baseline of first and second eyes. The secondary outcome was, of course, safety measures, both intraoperative and postoperative complications, and of course, the refractive error. We included all patients who underwent back-to-back cataract surgery during the study period, and we excluded patients who had missing data precluding the analysis of the primary and secondary outcomes. So at a full review, there were 955 cataracts done during the study period, 511 were delayed, and 444 were close with back-to-back surgeries. Unfortunately, these practices still use paper charts, so it was really hard to acquire all the data. So the data that was available was of 220 eyes, and you see the breakup there between the different locations. 2 patients who were initially scheduled for back-to-back surgeries ended up being delayed. And of the 220 eyes that were available, I further excluded 6 eyes because they were missing some baseline data. So in total, we had 208 eyes of 104 patients. Here are the patient characteristics: 68 average year age, 58% female. The average distance traveled was 31 miles. There was a range of 9 to 106 miles. About 17% had previous refractive surgery, and mostly started with their right eye. Pre-op data, the best corrected visual acuity is reported in log MAR. As expected, the first eye had worst baseline vision. We always start with the worst eye. That was significant. But the rest of the data was very comparable between the first and second eyes. Most patients got a monofocal lens, and about 13% in the first eye and 11% in the second eye had combo surgery with MIGS, which in this case was iStent inject, Omni, Kahoot blade, and Hydrus. So as far as the primary outcome, this is best corrected visual acuity. Again, pre-op, first eye was worse. 1 month post-op, they were very similar with great vision. And there was no statistical difference between the first and second eye and post-op month 1. This is the same data, just in a different graph, and it shows the 95% confidence interval with the first and second eye being very similar. Uncorrected visual acuity. Interestingly, the second eye had a worse average uncorrected visual acuity at post-op day 1 compared to first eyes. However, they recovered nicely by post-op week 1, and this was not a significant result. They had synchronous healing, so there was no significant difference in average uncorrected visual acuity between the first and second eyes at day 1, week 1, and post-op month 1. P-value was not significant. As far as the refractive outcome, we look at the spherical equivalent at the 1 month post-op, and this is patients who were plain on target only. It showed that first eye and second eyes were basically identical. About 71% ended up with within 0.5 diopters of the target, and then the first and second eyes were nearly identical, meeting between the 1.0 diopters of target, and the p-value is not significant here. As far as safety metrics, there were no reported intraoperative complications. For post-operative complications, we looked at 3 different things. First one was IOP spike on post-op day 1, and this was 10 millimeters of mercury above baseline. First eyes, 7 experienced IOP spikes. In the second eyes, only 3 experienced IOP spikes, but again, this value is not significant. As far as vision limiting corneal edema at post-op day 1, this was vision at 20/200 or worse. And 4 first eyes had that and 3 second eyes had that, no significant difference. And then there was no incidence of endophthalmitis. So as far as limitations, we had 104 patients, so not a huge study. And of those, 10 patients in our study had some missing data at post-op week 1 or post-op month 1. So to assess for the potential of the magnitude of this limitation, we did compare patients with and without this data and found that the results were nearly identical and had little to no effect on the p-value. As far as the analysis of the post-operative refractive error, we were unable to reliably ascertain the surgeon's intended refractive error. That's from the IOL calculations when you pick your lens. And that data was not transferred over to the clinic notes, which is where I got the data from. So I did not have that available. So we therefore uniformly assigned the target refraction to 0. And in conclusion, so when planning for bilateral cataract management, a 24-hour inter-eye wait time is effective at improving best corrected visual acuity with no difference in first and second eye result. It's safe with no significant difference in complication rate, and allows for synchronous healing, lessens the burden of anisotropia, and of course prioritizes patient convenience. Here are my references. And these are my attendings that helped out. Brandon Bartman, he's in Omaha, and then Greenwood is in Fargo, and Swan is in Bozeman. So I'd like to thank them. And I'd be happy to take any questions. Yes, Dr. Kapoor.
I have 2. You presented the initial visual acuity on the log mass scale.
Mhm.
What would that translate to in developmental acuity?
Yes, so let me see if I have that printed somewhere. I don't have it printed somewhere, but I believe the average baseline was about 240, 250. And then the average post-op at month 1 was Plano to 20/25.
And what percentage of the practice, these practices, the 3 different months you mentioned, of the patients that they saw were eligible for this? Or did they just say all comers and not distinguish between difference in cataract intensity?
Yeah, they did not they did not measure the difference in cataract intensity. It was all patients who were available during that study period. And who, obviously not every patient is a good candidate. Again, 18% had previous refractive surgery. About 58% had other ocular pathologies such as AMD, coag, fuchs, keratoconus, significant dry eye. So that was all taken into account as well for the selection of the patients.
So just to give perspective, rather than here, I mean, 20% of our cataract patients haven't had refractive surgery. So there's a huge population that we're looking at, and it's a different baseline.
Right.
When you do the sequential surgery, do you change out all the equipment? How does that work?
So for the immediate, which is not what this study was looking at, but I did talk on that. Yes, they switch out the equipment, they redrape, they reprep, the second eye. For this back-to-back surgery on back-to-back days, the patient gets their surgery, then they come in the very next day, have their post-op day 1 visit. And as long as there are no concerns, then they move forward with their second eye. So it's 2 separate operations.
Does the fact that the second eye is the same as the first eye mean it's actually worse? It's the second eye, if they were separated, you might modify your procedure to make it better with the second eye.
I'm trying to understand the question. Are you talking about like pre-op data or
Same as
post-op?
the first eye and the second eye were the same post-operative.
Mhm.
But normally you might use the first eye and maybe you gain from the first eye to adjust the surgery for the second eye to make the second eye better. So, right, you might be more on target with your second eye because you use the data from the first eye to adjust your surgery.
Right,
So
and
the
that,
fact same, does that mean that immediate, or the next day is actually worse than if you delayed it by 2 weeks?
So the refractive outcomes were all near Plano, so the outcomes were still very good. And the studies that I talked about at the beginning of the presentation talked about how they looked at using the data for the first eye to make changes for the second eye, and that did not translate into better outcomes.
That was great. I think the team, Dr. Sanders mentioned that always just trying to shift the dog on how you this is a leading question, but why are they doing it the next day instead of the next day?
I think allowing that 24-hour interim wait time, we do a post-op day 1 visit on the first eye, and if there's anything concerning, then we delay the surgery. In this case, only 2 got delayed. The rest were approved to move forward. And then I think another question that, is a whole separate conversation is the cost effectiveness. Obviously, there's been a lot of data put out that immediate sequential bilateral cataract surgery has a lot of cost savings. This surgery with a 24-hour wait time also has cost savings, but I think you still are able to charge for a separate surgery the next day.
I think that's the key there. And then you mentioned mitigation. Our concerns in ophthalmitis and practice outcomes, but the biggest one is honestly the person.
Right.
I was just looking at the CMS rules about it. I was thinking it's actually next day, so it's the calendar day that matters. So if you do a surgery 11 to 9, level 1, you can charge separately.
Yeah.
Why?
Yeah. So obviously the provider still gets paid for the second surgery. The patient, it's not really cost savings for them, but it's convenience for them, not having to drive, the 100 miles for all the post-operative visits and for the surgery, a month later, and having those post-operative visits. Yes.
Saying that there are cost savings with doing the surgery on the next day. What are those cost savings?
I didn't say for the next, I said for the immediate sequential bilateral cataract surgery.
So what are the benefits for doing like next day surgery? So we can get that.
So basically patient convenience, they don't have to, wait weeks, months, years to have their second eye done. And they don't have all the post-operative visits. There isn't that significant anisotropia between the eyes. The debilitating visual acuity in the phakic eye while they wait. So it's more about patient convenience for them, not necessarily cost savings for them.
But I know you're just conveying data and this you didn't do this, but I feel like my day 1 post-op on day 0. That's our patient for the patients, right? Instead of doing the next day and then patients come back again. And in terms of yes, some patients really don't want to wait 2 weeks to get a dinner a week. That's mostly for highly anisotropic patients like my groups. In those cases, maybe if that had been the eligible population for the study, I would understand, but this was just a general population that can make cataract surgery, right? But I guess I'm not very convinced or sold on the side of doing a surgery one day and the other. Same day, sure, in some situations, in particular patients, but the next day, I haven't seen it yet.
I have to look at cost savings, right? Because I mean, if we don't have multiple post-op visits to come for both eyes, I think week 1 and month 1 will be together. Yeah, I would think there'd be cost savings, especially if they're coming from far away. In that practice, particularly in Los Angeles.
Right, that, not to, just add to that, one of the practices that I know in Utah that I work with, they would get patients from Nevada, which is 6 hours away. There's no ophthalmologist, and so they could have their surgery over a weekend. I mean, basically a long 3 or 4 day weekend. So they'd come on, say, a Thursday and get the 1 eye done. And then the rest of the care would be managed in a co-managed fashion with optometry. So again, is it the ideal? Maybe not, but is it a safe option in the right setting? And I think that's we've had a lot of discussions over the past months and weeks about like co-management and stuff. And I think in the right setting, it can be a powerful tool. And so that's why I think this talk is as it's a potential tool in the right setting. But doing it if somebody lives in Lexington, in fact, bilateral simulated surgery, probably not.
Yeah, and at that point, it's their decision how they want to manage their cataracts.
I just wouldn't want to express this 2 days in a row. So
This harkens back to Darren Hill's investment research project, the post-operative restrictions we place on our patients, whether or not necessary, but since we still do, a lot of patients will take time off work, or if they're caregivers for kids or grandkids, they'll take time off from doing that, and so they can limit that to one week instead of 2 separate successes, 5 offers.
Right, yeah. What else? Any other questions? Okay, thank you all.
So thank you, Tanya, for your excellent presentation. Our next presenter is myself. And I have another retina topic, but Dr. Steinley's made set the bar pretty high, so we'll see. So my topic today is wide field OCTA in comparison to other imaging modalities in the detection of diabetic retinopathy. It's a bit of a continuation from last year, where there's a lot of just kind of technical issues that made our data a little bit strange and the analysis strange, so we kind of redid everything. But anyway, I have no financial disclosures. Here are my objectives, but essentially it's to establish the sensitivity and specificity of OCTA angiography. A little bit about the background diabetic retinopathy. It is the second most common microvascular complication of diabetes, and the current management is kind of based on observation and surveillance with dilated exams. You do OCT max, you do FA to monitor for any changes of progression, but only when it gets to advanced stages where we start talking about intravitreal injections. And there was a study done by Silva of 100 eyes that showed early changes in diabetic retinopathy starts in the periphery, and these predominantly peripheral lesions, they're associated with increased risk of progression over 4 years, regardless of baseline severity. And currently FA is the one that's kind of widely accepted as a gold standard of imaging in DR, but it has its limitations. And I think we all know one of the biggest limitations is invasiveness with a dye. So is there a comparable way to detect these lesions as early as possible? And if so, then how does wide field OCTA compare with ultra wide field FA and pseudocolor on this photos? So Optus is great because you can see a lot of these peripheral lesions, and there's an increased field of view. It covers about 200 degrees of the retina, which I believe is about 80% or a little bit over. And according to that Silva paper, again, Optus wide field is more sensitive in detecting these diabetic lesions versus standard ETDRS photos, which only cover about 30 degrees, and that's mostly the posterior retina, but it has its limitations. So colors, for example, they're not real, and you are taking something three-dimensional and trying to put it on this two-dimensional image, so there could be distortions that you see. The resolution is also not ideal. That was a big problem last year, where our fundus photos had a lot of dusting, and in order to kind of clear up the photo, you'd have to physically go back there and get rid of the dust. And I think only Michelle knows how to do that. I never figured it out. Yeah, and then there are certain diabetic vascular characteristics too. So foveal avascular zone, there's areas of non-perfusion. These are things that you can't really assess qualitatively on a color fundus photo. And then just kind of a study by Wessel, when comparing to FA, FA was able to show about 1.9 times more area of neovascular complexes everywhere and 10% more retinal pathology compared to just color fundus photos. So then we have FA, other than invasiveness. Other than invasiveness. It also has other limitations. I'll just ignore that. Rare but severe dye-related adverse events. It can be time-consuming, uncomfortable. It has limitations with patients who have severe renal disease or are pregnant. But the disadvantage is kind of more relevant to our study is with the retinal vascular anatomy. So FA can reveal flow at the level of the superficial capillary plexus, but when it doesn't quite reveal anything deeper. And then, of course, it's limited in evaluating choroidal flow defects as well, or defects as well. So there's that. And that's where OCTA becomes pretty useful. It's a non-invasive ultrasound machine. It takes multiple scans of depth resolved retinal and choroidal vasculature, and it results in all these various slabs. And you can see not just the superficial capillary plexus level, but deeper and deeper and all the way through the choroid capillaris. And of course, it doesn't require dye. And so that's kind of a big deal. And some other advantages that you see here. So finally, to our study, we did a one-year retrospective observational study. It was short of patients between or subjects between July 2020 through April of 2021. Essentially anyone who received a dilated exam, FA and OCTA on the same eye, the same day, got their images collected. So inclusion criteria: type 1 or type 2 diabetes with or without diabetic retinopathy, and I can kind of explain about that part later. And they could have been treated with either injections or laser, or they didn't have to. And exclusion criteria, as you can see, we had 43 total eyes, but we only included 32. It's because the other 11 had severe media opacities or just artifacts that would prevent any of our graders from being able to grade. So essentially, we organized all of these images, and I'll show some examples in the next slides of the AV and late phase for FA side by side, these color fundus photos, and the black and white retinal and the VRI slabs for the OCTA side by side. And the image that we selected was a 12 by 12 millimeter for OCTA, and that covers about 100 degrees of the retina, I believe. And we had 3 expert graders, which were the 3 retina fellows blinded to the images, and then they used this grading sheet. Just one second. Let's see if I can move this. Well, okay. These are kind of, it was qualitative, but anyway, these are the variables that they had to grade. They were mostly yes, no kind of grading systems. And in terms of our quadrants, the center was going to be the fovea, and then you have the quadrants around that. So we trained each fellow using a PowerPoint to demonstrate examples of all the lesions and the definitions. We kind of went over some of those images as well, just to make sure that everyone was consistent on the same page, to try to keep everything as similar as possible, similarly graded, I guess, as possible. And then they received some informal feedback later. Okay, and this is the grading software that or the imaging bank that we had. It's called the Vault, and those are the questions. So what do we find? Well, this is a table of our study population. Again, total of 32 eyes, and mean age of about 57, more males with type 2 diabetes and more proliferative diabetic retinopathy. And for those wondering why there are 2 subjects with no diabetic retinopathy, why they got an FA, it actually wasn't due to diabetes. We essentially enrolled anyone who got an FA and had concurrent diabetes mellitus and just happened to get that FA, an OCT MAC, and OCTA on the same day. And these 2 patients, one of them had an FA prior to PDT for PCV, and the other one was being assessed for post-uveitis activity. So this is some examples of the images that were graded. This is the same eye, left eye. So you see the Optos photo there, the color photo, and then we have the AV and the late phases, and the VRI black and white retinal slabs. All right. So in terms of the sensitivity and specificities, we use FA as a gold standard. That's what a lot of the papers did use. And as you can see here, kind of a general thing that we can say is OCTA showed overall high sensitivity to majority of lesions, not really the neovascular complexes. And they had a wide range of specificity values as well, mostly low, and for majority of lesions. Color fundus photo, on the other hand, just kind of had a wide range of sensitivities as well, just all over the place. But it did have a high specificity for IRMA when it was detected. So overall, I guess what we could kind of see from here is OCTA has kind of comparable sensitivity when using FA as a gold standard. And so then how strongly did the graders agree with each other? I had to use some help from the statisticians to figure this out. And so we use an exact binomial test because we're looking at agreement. And basically a significant p-value means evidence for at least 50% agreement between OCTA and FA and color fundus photo and FA. So you see here, there are several variables of significance. For example, OCTA, I would say what stands out are that microaneurysms, the agreement was about 90.6% of the time between OCTA and FA, and enlarged FAZ was 83.9%. And then if you look at table 3B with CFP agreement, FA, what stands out is, again, microaneurysms being detected, 90.6%. And disc neovascularization at 84.4%. So for kind of overall looking at these tables, there's just greater agreement between graders for OCT and FA than for color fundus photos. And I'll talk about more why I think that's the case. Cohen's kappa is really strange. And so I thought that Cohen's kappa would help us kind of more qualify or quantify actually the strength of agreement. So I have a scale that's commonly used for kappa, but as you can see, it's all over the place, does not correlate at all, or at all with the percentages. And I got in touch with our statistician, and it seems like our biggest limiting factor here is just the sample size, it's 32. And so that's gonna, they showed me some equations that they use for the kappa. They're very sophisticated. Don't quite understand everything about it, but essentially if you plug and chug some of these numbers, some will just automatically come out to 0. So the suggestion was just to get a bigger sample size. Yeah, so don't pay attention to Cohen's kappa on that one. So this figure is kind of a summary of the table. It's essentially like a raw agreement between OCTA and FA, and then versus the color fundus photo. So each colored bar represents a different imaging modality. So the yellow bar is FA, which is our gold standard, and it should be 32 eyes, except for I think 2 of those variables only have 30 eyes because all the graders said that they couldn't assess those variables. So we kind of couldn't include them. And then you find that the general height of the bars, like the green bars are a little bit higher more consistently, telling us that there was generally a higher agreement between, well, again, between graders for FA and OCTA, but then the blue bars, there are some high ones, there are more low ones, so it doesn't quite show much agreement there. Kind of to summarize then, I think I already said most of this, but overall, OCTA does have a high sensitivity to the majority of lesions, so you can say that it's kind of a comparable imaging modality when we are looking at FA versus OCTA, but because of the limitation of just 32 eyes, I don't think we can make a very strong concluding statement, especially with the specificity values. And another conclusion about OCTA I can say is there are 2 ways that you can exclude artifacts in the VRI slabs, for example. And one way is manual, where you have your technician just manually kind of go through the artifacts, and another way is automatic, and we use automatic. And so if there was a really nice, or actually if there was like a small neovascular complex and it just got excluded from one of the slabs just because it was automatically excluded, then that may have explained why you couldn't quite rule out those complexes. And then color fundus photos, just a weaker agreement amongst the graders overall, and sensitivities are kind of all over the place, so not as comparable there. Strengths of our studies compared to others, we used a higher scanning speed, and so hopefully definition resolution was a little bit better. A lot of the other studies didn't have that aspect. And then we used our VRI slabs to try to more clearly identify neovascular complexes. But as you can see, artifacts can always be an issue. So again, these are limitations. Cohen's kappa doesn't really make sense with just 32 eyes. That was a huge limitation here. I would probably have a more stringent exclusion criteria, but the reason that this study worked with those 2 patients who didn't have any diabetic retinopathy was because we just wanted to see how people could detect the lesions. And then in the future, maybe consider DME treatment history and those who were treatment naive, and finally address technological difficulties and look for better images with higher quality. So OC is exciting, it's not perfect. As you can see, these are some of the reasons why. The wider the field of view, the lesser the resolution, the more acquisition time and the more artifacts. So you're just kind of balancing between or picking and choosing your poison there. And I mean, at our clinic, of course, if you get an OCT, I don't think they pay for it, you just get enrolled. But in the future, the cost and billing impediments are always going to be an issue for more current or more recent technologies. So that's kind of what I have. Many thanks to Dr. Maldonado, who's not with us today, and our retina fellows and the ROGI lab.
Can you go back to your specificity sensitivities?
Yes, yes, yes.
So for the microaneurysms, you had 100% sensitivity, basically.
Yeah.
Does that mean essentially that all of the graders said that every picture had microaneurysm?
So that's a good question. When we were talking with the statisticians to see what were the best rules to use for graders in order for them to do their math, essentially we have 3 graders. And Shivani was the senior grader. So let me see if I can pull up all of our rules. Hold on, just one sec.
Well, I guess my question is that, you know, the specificity would tell you there are any 2 negatives in the sample. If no image had no microaneurysms, that would explain why the specificity.
Yeah, and I think some of these, but when we're calculating sensitivities and specificities in general, we have to use 3 rules, grading rules essentially. And kind of to clarify, if all 3 graders disagreed, then the most senior experience, basically their answer was chosen as true. And if the most senior was unable to answer, which is one of those answer choices, and the greatest overall agreement determined by this huge math equation by the statisticians, that would tell you which one was the true answer. They use like an IBM software program for that. And if the first 2 graders were not able to answer, but there was a 3rd grader that actually responded, then that would be the true answer. So those are kind of the rules that might affect our values over here. Okay. Thank you. Okay. So our next presentation will be by Eric Peterson on orbital exenteration, indications and outcomes, a multi-institutional retrospective study. No, not that one. Okay.
What?
I don't know this one.
I think it's somewhere here. Oh,
Is it? No, it's not.
oh, that's one. The one says Peterson. Yeah. Oh yeah, skin sign. Good morning. I'm Eric Peterson. I was fortunately my talk's pretty short, so I wanted just to take a bit and talk, because that's really what I think the award was the most talkative or the loudest resident. But thanks, Mike. thanks to my residents for letting me practice teaching. By the end of the year, I realized I spent so much time. I didn't get anything out right the first time, so by the end of that conversation or answering the question, I felt like I had to go back and summarize. So it'd take 1.5 times longer than it could have if I just gotten through it, because they always understood it either way. But anyways, everything just took longer with me or listening to me. But also wanted to thank all of you all that are here. Due to my rotations, I won't be leaving for Virginia in just a few days, and so this may be the last time to get to see some of you. But I was just thinking about it, and I think I've done a globe with just about everybody in here. Definitely operated or been in clinic with just about everyone, and so it's really been a good, great 4 years, and it's kind of come full circle. Me and John Riley, and I think Nikki and Angela, I think all of us were here 4 years ago when, as brand new, 2 weeks from starting, looked up, and I guess who would have been the next class, and they were giving their presentations, and like, oh, they're so smart. Oh, we're going to be there with someday, and reality is now we're not there. Stuart's still way smarter than me, that I recall. At least for me and John Riley. Angela's given enough presentations. I think she's gained some intelligence over the years. The last thing I was gonna say was there's a difference. I mean, Angela and Nikki are both going to go do fellowships and change the world, and me and John Riley are going to go to those places in Virginia where there's no other ophthalmologists, so they won't know the difference. So we're excited either way. Because I can be long-winded, I wrote everything down, so I'm just going to read off my phone because that's where the notes are. And we'll keep this short and then still get time to hear the remaining presentations. My name is Eric Peterson, PGY4 resident. My project this year is titled Orbital Exenteration Indications and Outcomes. We were approached about a year ago by the University of Louisville seeking cooperation on this multi-institutional study regarding orbital exenteration. Coincidentally, as some of you may recall, I just completed analysis on enucleation indications and demographic study last year at the time, and we were able to extend some similar analytical themes from the enucleation study to this current one. I would like to acknowledge use the mouse. I'd like to acknowledge several individuals who are involved as they perform much of the critical work. Kayla Switek, a newly graduated UK medical student and soon to be ophthalmology intern, spearheaded the project here at UK under the mentorship of Dr. Timoney. I would also like to acknowledge the undergraduate students, medical students, and faculty from the University of Louisville and the University of Kansas. I have no notes there. I don't think I have financial disclosures, but I have no financial disclosures, and I actually don't personally know anybody who makes prosthetics for exenterated orbits either, so no financial disclosures. As a review, there's several different variations in the type of exenteration. Last year, you probably got my not exhaustive review of enucleation, but in terms of exenteration, the goal is to remove most of the soft tissue of the orbit. Primarily, this can be summarized due to two indications, either malignancy of the orbit or of the eye wall itself, or infection, either panophthalmitis or fairly common, still not commonly, but something like mucor, some sort of invasive fungal sinusitis that's risen to the orbit. So on the left, you can see the most typically uses what's called a total exenteration, where you remove all the soft tissue all the way back to the apex and anteriorly. The incision is usually made near the orbital rim. Another one that's gained traction recently is a lid sparing, where you make a subciliary or a superciliary incision is to salvage to save the skin. You're still taking the margin and the tarsus in that dissection, but you're saving the superficial skin, and that helps with closure and graft coverage. A more literally radical version is the radical exenteration, where you're taking some of the bone, and this is used in invasive malignancies as well as invasive fungal sinusitis. And then the last is a partial or subtotal anterior exenteration. This can be lid sparing or non-lid sparing in a similar fashion to a total exenteration, but you just leave some of the posterior orbital tissue. On the right is a gentleman, this is on the AAO website as an example of what a prosthetic might look like. I think the majority of the prostheses are some sort of metal implant with involves either a hook or a magnet to secure the prosthesis. But as you can see, they look fairly well given what the patient has gone through to get to that point. We included all the patients that underwent from the years of orbit exenteration at the 3 facilities from January 2010 to December 2021, as identified by the associated CPT code. 69 patients were included. 4 patients were then excluded due to insufficient postoperative documentation. These are the outcomes that we looked at: the indication, the distance to the facility, the time from diagnosis to treatment, time from treatment to last follow-up, the exenteration type, remodeling technique, complications, recurrence, survival time, and prosthetic use or given. I'm shaking so much, I'm still cold. I'm not too nervous anymore, but the highlight, the points on this busy slide I want to highlight was just that 81% were malignancy and 12% were infection. And again, this was most commonly fungal sinusitis. And 12% were due to infection. 63% are male and 39% were female, which interestingly is nearly identical to the enucleation study I presented last year. There's a almost 2-to-1 male predominance. And I looked at another study between the years of 1993 and 2011. Traylor and colleagues from MD Anderson presented a study including 180 patients who received orbital exenteration entirely for craniofacial malignancy. So that's a pretty high volume, but they are a significant referral network. Between 2003 and 2013, Naginjan and colleagues from Mass Ioneer presented a similar study with 25 patients. 92% had associated malignancy and 8% had associated infection. So our numbers were more similar to Mass Ioneer, about 25 patients per institution over a 10-year period, with kind of 80 to 90% malignancy with a few infection. The orbital exenteration procedure type was categorized into total, which is about 30%, subtotal, which is also 30%, and radical, which is 40%, and that adds up to 100. 32% of patients had positive margins postoperatively. Of the 65 patients in the study, 26 received a prosthetic. There was no statistically significant relationship between type of procedure and indication for exenteration, between the type of procedure and the subsequent remodeling technique. The type of exenteration performed had a statistically significant relationship with disease recurrence, but not margin positivity, and that's what I highlighted there. And I think the biggest difference is that between the total and subtotal. Interestingly, the radical exenteration had more occurrence than a total exenteration, but that was most likely could possibly be explained by the nature of the disease process that would warrant a radical exenteration as opposed to a total exenteration. But I believe that's where the significance comes through, is between total and subtotal. At MD Anderson, they also found that the presence of perineural invasion and positive margins were associated with progression-free survival, but only perineural invasion was also associated with short overall survival in their malignancy patients. At Mass Ioneer, their numbers were 44% had total exenteration, 32% had also total expression, 44% had non-lid sparing total exenteration, 32% had lid sparing total exenteration, 16% had lid sparing partial exenteration, and 8% had non-lid sparing partial exenteration. So we just ended up doing a lot. This includes more radical exenteration. That could be a little bit of surgeon preference, also the indication and disease pathology may be different. 44% underwent additional extraorbital procedures. Of patients with malignancies, 48% had clear margins after exenteration, and at their study, there's no statistically significant difference in survival between patients with negative surgical margins compared to the positive margins, which is an interesting comment that we've talked about, I think, with several people that deal with cancer, especially with in Dr. Timothy's clinic. You know, he'll cut a sample off and have a positive margin, and often just watch it because just the surgical destruction has perhaps removed those final, you know, cells and stuff. So just because there's a positive margin doesn't mean that there's residual cancer in the tissue. Although and from these studies, it kind of suggests that even if you have positive margin, that doesn't always reflect with positive increased rate of recurrence. And last couple slides here. This just shows the types of complications. So half didn't have any complications and the other half did. Most commonly was infection. There also can form a fistula, the CSF leak, dehiscence of the wounds. This was kind of all forms of dehiscence, respiratory failure. I forgot to ask Kayla what that happened, if that's on the table or afterwards. And then most the bottom two are equally concerning of tissue necrosis, loss of the graft, or bony defects and exposure, which is an increased risk of infection in a high concerning area. By comparison, MD Anderson reported their overall complication was about 15%. So we definitely encountered a higher rate than they did. This is a Kaplan-Meier curve, not on overall mortality, but time to follow up. So Dr. Bastos, nobody followed up. That's what this is saying. By 1 year, we had lost 75% of patients. By 3 years, which is the red mark, the second red mark, we had lost 90%. And by 60, only 1% remained. So I think one person showed up for his 5-year follow-up, which is not, unfortunately, is a common theme in when I've done, at least the studies I've done here in Kentucky. It's pretty hard, especially for something that's like an ongoing process. Especially exenteration of prosthetic, they're much generally a higher rate of issues compared to an enucleation. And the prosthetic fit is different, and it's much more has to be individualized. So in our study, there was no significant relationship between surgical indication and time from exenteration to follow-up or from diagnosis to treatment. By the last follow-up, 9 malignancy patients, 3 infection patients had died, which is about 20%. And those are the ones, of course, that we know about. At MD Anderson, they had a longer follow-up of nearly 10 years. At Mass Eye Near, they had some more studies. There was analysis. There was no statistically significant difference in survival between patients with negative surgical margins compared to positive margins. Kind of what I talked about earlier. Mortality was highest in patients with melanoma, almost 86%, and lowest in patients with non-squamous cell lid malignancies at 0%. Survival rates were 72% at 1 year, 48% at 3 years, and 37% at 5 years. Again, with follow-up, they were actually able to track some of those things. This is the last data slide. So demographically, you can see on the top is the distance from the tertiary care center versus the time to exenteration from initial diagnosis. And there's a weakly positive correlation, meaning that the distance did contribute to a slight delay. And this was weakly positive, but still there. And then the second graph is distance from the tertiary care center versus how long that the length of follow-up. And there was a decline. The farther out, there meant a shorter follow-up time. And then finally, there's a kind of a bimodal distribution on the prevalence of complications versus the distance to the tertiary care center, people within 50 miles, and then people from 75 to 100. And I forgot to ask Kayla again how that they ended up deciding the calculation. But what I did last year was the county seat, kind of the central county where the patients resided in versus to the distance to the facility. So hopefully, I think similar to what I did. And then I think I had some comments. That was it. All right, summary. This study demonstrated a relationship between the type of orbital exenteration performed and disease recurrence. There was a relatively high postoperative infection rate among this population, coupled with poor postoperative follow-up. The biggest limitation is the sample of the study was small, and I forgot to add that the length of follow-up was, or there's very low follow-up. Overall, this is an interesting procedure and disease kind of process. Patients that need this exenteration, it's very rare, and it's unfortunately has to be fairly individualized due to the nature of the patient's underlying malignancy or their infection. And so it's hard to really kind of generate large or useful data. But I think the two things I got from this is, one, why did only 25% get prosthesis? And two, why was there such a loss of follow-up? And those would probably be the main points that I would be interested in looking at going forward with something that is so debilitating.
I don't want to.
That's okay, Dr. Conklin. Thank you. Thank you all.
Huh? What now? Yeah,
And just so you know, if there's any
it's
questions,
written there.
John Riley to fall over.
Karsner, Karsner.
We can still hear you, Dr. Conklin.
Okay.
What do you mean? Died? No, Karsner?
I think we're more. There it is. I'm trying to see on here. Nope, don't want to invite him. Here, my screen is like out. Hold on a second. The screen's not recording. That's why it's like out of the screen. That's why. Right here.
Click on one. Oh no, we don't want to. So way to mute, like right
I
click
know.
on.
Just mute everyone.
Oh. Yeah.
He cannot be muted.
No, because we're not the host.
No, we're not the host. We can't mute him. That's okay. All right, so our last resident presentation today will be Nikki West. She'll be talking about trends of overnight weekend ophthalmology consults this year and 8-year review.
All right. Hi, everyone. I'm the last one. So hopefully this will be a little bit of fun. Usually is, at least for the residents at the end of the year. Finding a little humor in our, overnight consults, our sleepless nights, as PGY2 especially. And just kind of looking back to see how many patients we actually did see, overnight and on the weekends.
Do you mind to turn your video on?
Oh.
The Zoom people can't see your face.
Where's the video?
Just go to the Zoom and click that token. Or you might need to exit out your.
Upper at the top.
Oh, right there. There we go. Yeah. Then start video.
Oh, there we go. Okay.
Oh,
All right. Yes. Okay. Okay. So just special thanks to all the residents that have done this presentation before me, and Dr. Moore as well. No financial disclosures, of course. So basically just kind of look back over the year and see, pathology, volume of overnight weekend consults, compare kind of call trends previous year and years, and then kind of look at, who got to see the most patients. So every morning we send out a checkout email of patients that we're seeing on call for follow-up. We say the reason for consult, exam findings, treatment plan, and the follow-up plan as well. And so data collection actually began 2014. So that includes date, diagnosis, pathology, and then resident as well. And then the consults that I included were only overnight or weekend consults that were new UK consults. So this does not include patients that were seen as follow-ups in the clinic or in the hospital. And then this consists of UK, Good Sam, and at the VA, which we restarted going to see patients there as well overnight again. And then it doesn't include any hotline calls if the resident did not go in to see the patient. If they did, then that was included in the numbers. So here's a little look at the volume over the past couple of years. As you can see this year, we had about 80 more consults than last year. And it's actually the most we've had, beat 2017, 2018, which we hadn't had that much volume since then. So about 7% more consults than last year. So it was pretty busy this year, I would have to say. I think the first years were pretty hard. Oh, just use ours. Okay. So per location, of course, UK was our most common. We saw 57 at Good Sam and 34 at the VA, and then we had 21 no-hitters, which is basically described as you didn't go in to see a patient. Now that would include if you got a hotline call, but you wouldn't have to go and see that. So that I call would be a no-hitter. So Good Sam, we've been seeing more and more patients there every year. So 5% this year were from Good Sam, up from 3% last year. And I think the year before that, it's been up like a few percentage points like every year. So going more and more, and we're going more and more for consults as well. So this is just calls by month. Actually, this year, May has been our most busy month. I feel like usually traditionally like July and August are more busy months. But yeah, May takes it this year. And, of course, we're still in June. So, and then we always see that little kind of January, February around winter time. And then this is just saying, Saturdays are our busiest days over the weekend. Sunday, actually, this year has been busier than past years. So a lot more to see over the weekend. As you can see, Fridays are, pretty the busiest, weekend or weeknights, followed by Tuesday, which is kind of interesting because usually it's Monday, but. And here is the interesting slide that we all like to look at. So these are calls per resident. So 1 through 4 are the PGY2s, and 5 through 8 are PGY3s. And then number 9 is a senior resident that got to see 4 new consults. On primary call, she missed it so much that she really wanted to go back, disabled her junior's pager. So that's what she wanted to. So I don't know, you can kind of speculate who's who a little bit, but compared to previous years, this is just per resident. And so the resident that sees the least is usually around 190. So that's pretty similar comparative to this year. And then pathology has pretty much, stayed the same over the past couple of years. I mean, most common being, the corneal foreign bodies and abrasions, orbital fractures, which has actually been going down for our orbital fracture protocol. Another thing that's been going down quite a lot actually is our NAT consults for our new protocol, them having to have a positive CT head finding. This year we had a lot of optic disc edema. There's like 40 some consults for optic disc edema. I think last year there's only like 10 or 15. Now I don't know if that, there was some more optic neuritis that was called, but really a lot of optic disc edema this year. And then PVDs, we had like 60 some of that, and I think year prior was only about 20. It's not on this graph, but Another thing to look at is open globes. We had thankfully less than last year. Last year I had like, 58 or something crazy. So all of them got about 20 globes. This year, I think all of us are around 10. So, but those are kind of the most common things that we're seeing. And overnight procedures, so most common are ulcer scrapings, even got a little higher than last year. Laceration repairs went up, so did corneal foreign body removals. I don't know if like the EDA just hasn't been doing as much of those as they had in the past. Quite a bit of, endophthalmitis, so tap and injects. Had a few corneal gluings this year too that had been up from previous. So, and then, so we kind of already talked about the no-hitters. This slide very much surprised me. So Peter, was really at the top of the running at the first of the year for Black Cloud Award, but he really lucked out this past spring and had most no-hitters this year, which is defined as like no new consults, so having calls. And poor John Bader had 0, so sorry, man. And then consults to Good Sam. Peter did win again on this slide. And thankfully, John Bader, you didn't have any no-hitters. We didn't have to go to Good Sam too much. So, and Tanya also is up there for no-hitters and not going to Good Sam. So kind of Hall of Fame, besides the trauma cases that come in because they're minding their own business and everything, like that. We did have a kid that came in with basically had a needle just right through his sclera into his retina. You could actually see it on indirect ophthalmoscope. It was referred from an outside optometrist, and apparently you could see the bevel and everything. Still unknown to this day how he technically got the needle in his eye. But I believe it took them to the OR, did well. I think it was like right through the pars plana. I don't think you even put a suture in. I don't know what the gauge of the needle was. I don't know if that was. It was a 30 gauge. All right. And that was it. There we go.
And he's 2020.
And he's 2020 and doing great. Perfect. Good job, Dr. Fraser. And then there was another gentleman helping his cow birth a calf and got headbutted. Had an open globe from that. Be careful when you're grabbing your bag of chips for a snack because you can get a corneal abrasion from that as well. Also, be careful in the club. Apparently gonorrhea on people's elbows. So we got a nice hot chick movie, if anybody has seen that, early 2000s, but picturing there. And then there was a mother that came in after her child had put cleaning solution in her contact lens case. They were trying to be helpful, probably, but yeah. Yes. We did have a gentleman come in for a BRVO after he had ingested cocaine crushed with Adderall, muscle relaxers, and then he had also, on top of that, consumed alcohol, mushrooms, and marijuana. So, just had to get everything. There was a bug that was stuck under a plica that was removed. I feel like that's kind of common, but I thought that was interesting. And then Cody, I think, got this great consult. A patient was tearing. He went to see the patient, okay, like, let's see, and I guess told Cody that he was crying tears of joy, and that's why he was tearing. I don't know why he was crying tears of joy, but apparently that's what it was, and so probably just because Cody came to see him, but
Symptoms had resolved by the time I got.
yes. There's a lot of other consults that were kind of crazy this year, but just kind of a few of the ones to look back on. And to our regular Black Cloud, White Cloud Award. So we have Paris. I feel like he just sees everything. Any patient that walks in, he'll just go and make sure see if they need any have any eye complaints. He'll make sure that they do. He'll treat them and even refract them overnight. So, and Shane, of course, is. Thank you. Any questions or?
Well, I'd like to make a comment.
Yes.
No one believed about the needle.
Yeah, I know.
That was a motivation for building my device.
Check drive this time. Let's see if I can get it over there. So that's that. Where do I put it? How do I get it on? There you go.
All right, thank you, Nikki. So Dr. Nathan Stone is back for his second talk, and I think everyone else is here too. So welcome him back.
Thank you. All right, so this is much more practical. So I thought this would be like the one you actually remember, right? The first one is data driven, and hopefully that drug sees the light of day, but we'll find out. So I did a talk like this before, and I remember at the end it was a good talk because people came up and asked me a zillion questions. So hopefully you guys will interact with me tonight and get some pearls from me, and hopefully you'll learn something today. I remember one time I went to a talk like this, and Kurt Packo, some of you guys know Kurt Packo up in Chicago, and just an awesome guy, great lecturer. And he was given clinical pearls once, and he was given real world advice. And he says, Stanley, sometimes you get behind in clinic, we all get behind in clinic. And if you get an hour behind, but if you get 2 hours behind, what you do is you go out to the waiting room and you say, I'm so sorry, everyone. I'm so sorry. I had emergency surgery, right? And everyone's like, no, it's understandable. We'll wait 2 hours. If you get 3 hours behind in clinic, you go to the waiting room and you say, I'm so sorry, I had emergency surgery on a child. And no one says anything then, right? No one's going to complain then. So all right, this is real world practical advice. So let's see what we can do here. All right, so I've been working really closely with industry for a long time, and hopefully makes me really unbiased, so I get pulled in every direction. And I really learned a lot from Andy Pearson when he was here with all his work with steroid implants. And then I went to the Cleveland Clinic with those guys. They're involved in a lot of different industries. And so I felt like they were really unbiased. So they got pulled every single direction. And so the more companies I can consult with, the more research I can do, I feel like I can bring more of that to my patients. I speak for pretty much every single company too, including just yesterday. I'm now going to start speaking for the new biosimilar that came out, which is a whole new world now for us to have a, Lucentis biosimilar that's on the market as of now too. So these are going to be real world tips, and then a cool little photo to keep your guys' kind of imagination of what can be possible. So I sat in your exact same chair 10 years ago, and now I've moved on, and this is some of the places ophthalmology has taken me. So this is Michael Singer. Some of you guys know Michael Singer. He's down in San Antonio. This is the Alamo. I'm a diehard Spurs fan too, so it was really fun to go down there and get personal tickets. He's the eye doctor for the Spurs, so it was really fun to go down there and take in a game and do a talk down there in San Antonio. So my typical week, what's my week like? So I do clinic about 4.5 days a week. I have 2 half-day surgery blocks. So I do a morning on Tuesday morning and a morning on Friday morning for surgery. I do clinical research every single day. We have about 25 clinical trials we're enrolling in. So it keeps us very, very, very busy. We do everything, RVO, DME, DR. We even do some neuro-ophthalmology. And it keeps us very busy and hopefully on the cutting edge. We have about 20 full-time clinical researchers that we work with every single day, and keeping track of it all is a big business, time commitment for us, but something we're very motivated for. We commute. So we have 13 clinical offices in California. So I commute most days about 45 minutes to an hour each way. 4 days a week I commute. 1 day I'm in my home office. And we just repeat that over and over and over again. I do have Saturday clinics. Saturday clinics in Bakersfield are extremely productive. If you want a little tip, do a Saturday clinic once in a while, and you'll get patients who have amazing good commercial insurance that can't come in Monday through Friday, but they want to see you on Saturdays. You'll get the policeman, you get the fire officer, the banker who can't get off during the week, but they got great insurance. They want to come see you on Saturday. It's a good way to build a practice. All right. So number one tip for you guys as residents and even as fellows, record and watch your surgeries. I still do this. I still record and watch my surgery. So every single surgery I do, record it, and I go and critique myself. There's so much you can learn. There's so much you can learn every single time. You think I've done a zillion cataracts. I did surgery yesterday morning. I did a cataract yesterday, combined surgery. I still knock out surgeries, routine anterior segment things. Thanks to the great training I got here And so I knock out cataracts all the time, and I still learn things. I still watch my techniques all the time. This is me. You anyone know what building that is right there? That's yeah, Burj Khalifa. Yeah, in Dubai. That's the largest building in the world. So pretty cool. I gave a talk there for Alamir a couple of years ago. Try and scrub with your partners, especially at first. So when you first come out, right, everyone's going to want to know your quality. They're going to be scrub with you. And so they want you to kind of have some quality control. Make sure you scrub with your partner as much as you possibly can. Because when you get busy, it's almost impossible for me to go scrub with one of my partners now. I'd love to go scrub with my partners if I possibly could, just to pick up the simplest tip. How do they insert the trocars? How do they manage the IOP during a surgery? I would like to learn all that. But now I'm just too busy. So if you get time early in your career, go to scrubbing with your partner as much as you possibly can. Even if they're old, you'll learn stuff. All right, you just will. This is Mexico City. This is a talk I gave in Mexico City a couple of years ago. Rishi Singh Dil should do it. A whole bunch of international friends I have now from talking internationally at Mexico City. Next tip. Really, you can do this. You can publish or present one project every single year. And every single year, just get something you can do. Submit something to the academy, submit something to your society, do a local one for the state. People want to hear you talk. Submit and publish one thing a year, something you can really, really do. We had a great meeting not too long ago in Mykonos. So this is Santorini, Mykonos, and actually that's also Santorini there. So there's always great international meetings you can go to, you can present. There's always opportunities that if you take advantage of them, they're there for you. Keep in contact with your mentors, right? So I have a huge text chain of people that I contact all the time about things. Simple stuff. Like I had a patient the other day come in with silicone oil and I wanted to give him an Ozurdex. I was like, I haven't put an Ozurdex in silicone oil for a while. I just texted out people, can you put an Ozurdex in silicone oil? Absolutely, no problem at all. So I did it and the patient's doing great. And it's nice to have those contacts you can just contact if you need to. So keep in contact with your mentors as much as you possibly can. And it takes effort. It really does. Because at the end of a busy clinic, right, the last thing you want to do is go text your friends or, you just want to go relax sometimes. But keep in contact with mentors. When you see them at meetings, I always have a group of 4 or 5 people. Every single meeting I go to, I have a drink with, try and keep up with them so we have those friendships, maintain over time. This is London. This is Retina Society just 2 years ago in London. People you might know, Caroline Bummel, Barakal, Dan Martin, Sumit Sharma, Dave Brown, good people in Retina that they're all personal friends of mine because of these meetings, so these talks I get to do. Stonehenge on the other side. Text, email reps after they visit. So when a rep comes to visit you, you are on display, all right? It took me a long time to realize that. But when a rep comes to visit you, you're on display, and they're going to take that information or whatever they saw to the next place because they like to be vectors of information. They'll take good information, they'll take bad information, and they'll pass it to other practices. They're also kind of ambivalent as far as who they're talking to. They don't really understand referral patterns. They don't really understand, financial patterns as far as surgery centers go. They don't really understand, commitments for certain things. So they just simply will spread information. So make sure if a rep comes into your office, treat them with respect, treat them with kindness, but also just know anything you can tell them will be spread to the community and they'll take that information. And so you might as well have them be vectors of good information, especially when you're first starting out, right? Everything's going great. Clinic's going great. Everything's going great because they will take that information and they will spread that information. Also keep in contact with them. I had someone bring me lunch yesterday. And so afterwards I said, thank you so much. Big hit for my staff. My staff loves lunch. And so it keeps that relationship open. This is a talk I gave in the Middle East. I actually got to go to Kuwait, Abu Dhabi, and Dubai. This is a talk I gave for a uveitis conference. So pretty cool. All right. If you have a complication, give that patient your cell phone number. If you operate, you're going to have complications. I do between 12 and 15 vitrectomies a week, right? That's a lot, 10 to 12 on average, sometimes 15 to 17 in a busy week. You're going to have complications. You're going to have that patient you wouldn't expect to have a non-clearing vitreous hemorrhage afterwards. You're going to get an endophthalmitis. You're going to have a low pressure. You're going to have a high pressure. And if you have that patient have your contact information, they feel they have that conduit, they have that contact to be able to get a hold of you. That is such a peace of mind for them, and it saves a lot of headache for them, and it helps you kind of get through the process too, right? No one wants to have complications, but if you're going to operate, you're going to have complications. So make sure you communicate with those patients. Also schedule them appropriately for your clinics, right? So when I have a complicated patient and I know they're complicated, I make sure I schedule them the very end of my morning or the very end of my afternoon, because I want to be able to spend as much time as I can with that patient. Worst time to schedule in the middle of my clinic, 10 a.m., 2 p.m., right? Those are rough times because I got 17 patients to see. I book between 80 to 100 patients a day. Yesterday, before I flew here, I saw 84 patients, right? So if you have a complicated patient, you have 2 complicated patients, you could throw your whole clinic off, right? So you have to be smart about how you schedule these patients. Otherwise, they're going to feel shortchanged. And if they feel shortchanged, that's a patient who's going to get litigious. That's a patient who's going to write bad reviews. So simple thing, make sure the lines of communication are open. Munich, I got to go to the last Oktoberfest. This is in Munich. It was in 2019. They canceled it in 2020 because of the pandemic. They canceled it last year because of the pandemic. And hopefully next year they'll have it again. All right. Remember everyone's name. This is just simple stuff, right? It's amazing you have to give a lecture about this, but we have 150 staff now on my payroll in my company now. So we have 13 surgeons, 150 staff. I can't imagine how many staff are here at UK. And that's just my clinic staff. I have 5 different ORs I operate on, right? So on certain days I go to different ORs. So I have to remember everyone's names. That's the sweetest sound to them, right? Is everyone's names, right? And everyone knows be disrespected if you work with someone for 2 years, 5 years, 7 years, you don't know their name. And it gets embarrassing. I've been there myself. So just make sure you somehow find people's names and then find a way to remember it. Because if you do, they'll bend over backwards for you. This is, I always come back to the Derby. I've been to the Derby many times. This is just, I even went during the pandemic, and amazing story. So this is Timothy. I always come back and visit him when I'm here. This is my patient right here. And he's a high roller, and I fixed his detachment. So he was in Houston. He's an oil guy, and he had a detachment at Baylor. And so he wanted to fly back to California, but obviously he can't fly back with a bubble. So Baylor called me because I know the people at Baylor. They said, "Hey, Steinley, can you take this guy on as soon as he lands?" So sure enough. And so he flew back to California, and I took him on. He's done really well. And as a treat, he took me to the Derby recently. So super good story. So these connections kind of build over time. So remember everyone's names. It sounds so simple, but it's actually harder than you think, especially when you get busy. All right, this is another simple one, right? What you can be judged on when you first start is time. When they're watching you operate, they really don't know quality, right? I could be doing enucleations and people don't really understand what's going on. They just don't. But they know time. They know if you're ahead of schedule. They know if you're behind schedule. Dr. Stein's behind schedule. What's going on today? So if you're just starting out, give yourself peace of mind. Book yourself plenty of time at the OR. If you think your cataract's going to take 10 minutes, great. Book it for 20 minutes. If you think your vitrectomy is going to take 1 hour, great. Book it for an hour and a half. Give yourself plenty of time, because then the staff's going to be like, dang, he's on fire today. He's ahead of schedule. And it really, they don't understand that your membrane peel took 2 hours, right? But they just know you're ahead of schedule, and that's all they know. And so might as well get that positive vibe going rather than be behind. So book yourself for 150% of the time when you first start. This is a cool experience. So I've been doing a lot of wet labs. This is actually in Memphis. And the reason why we do it in Memphis is because they have pigs. And so you can go down there and you can operate on intubated pigs, and you can do retina surgery. So this is for Regenix Bio doing subretinal surgery in intubated pigs in Memphis. So never done that before. It's a really interesting way to create the blood for the first time on a real live pig. All right, home gym and healthy lives and disability insurance, right? So this is me just last week. This is on Sunday. This is in Monterey, right? So you get into crazy stuff, right? And you're going to be the product of your decisions. You're going to be the product of your decisions, right? So make good decisions. Everyone's going to have 60 minutes per day that you're going to decide your future with. Everyone's going to be busy. You have clinic to do. You have home responsibilities. You have church responsibilities. But you're going to have 60 minutes of free time that you're going to decide how your life's going to be shaped. Make sure you make a decision. So this is one of the things I've been doing a lot of is running. And so I just qualified last week. So this is a half marathon in Monterey. And I qualified for the World Championship for Spartan, which is pretty cool. So it's one of the things I like to do. So make it easy on yourself. So take a salad for lunch, make sure you have a home gym, and make sure you have good disability insurance, because everyone's healthy until you're not. If you had, think of it a different way. If you had a printing press at home, right? And the printing press at home made money, and that's all it did, right? So makes money, makes money. The first thing you do in the morning is go check on that printing press, and the last thing you do at night is check on that printing press and make sure it's printing money, right? And so your biggest asset, I don't care who you are in this room, your biggest asset is your ability to make money. That is your biggest asset. I don't care what you invest in, how smart you are, what the market does. Your biggest asset is your ability to make money. So make sure you protect yourself. Make sure you take care of yourself, because you're a printing press every single day you're alive. And if you don't take care of yourself, that press breaks down, right? So remember, your biggest asset is your ability to make money. All right, hire a maid. So make your life easy, right? The best money I spend is having a maid service, right? It sounds super bougie, right? But it's the best money you can spend. So it's like $20 an hour. So if I pay someone $100 to come to clean my place or clean my car, it's the best money you could ever spend. And you can see 2 more patients, 1 more patient, and you go home to a happy household, clean household. It's the best money you could ever spend. So anyone know what this is? This is Prague. Pretty cool. Representing the cats in Prague. I had a meeting out there. It was actually I'll show you another picture in a second, in Austria, and then we popped over to Prague to check out Prague. All right, number 11, automate your life, right? You all get pulled in different directions. So as much you can automate your life, do it. So make sure all your bills are on bill pay. Make sure your staff is automated as much as possible. So I love doing mission trips and going to see how other countries do it. And their thing is, if someone else with lower responsibility or lower training could do what you're doing, then let them do it. If it's eye drop, if it's prescription refills, if it's, writing DMV forms, if it's, whatever form comes with disability forms, make sure your staff is doing that for you and automate your life. If you're doing low level things that's not using your full capability, then make sure you have that assigned to someone else. And they actually take this pride in it. You get judged on how you fill out forms. So if I have a patient who comes into me and I fix their MAC-on detachment and they're 23 years from now, they don't hardly remember my name. But if they come in with a DMV form and I make them wait 2 months to fill out that DMV form because I was busy, I put it in the back of my pile, I have to do it myself instead of delegating to someone else, they remember that, right? Same thing with disability forms. People know if they don't get their disability. And so you have to fill out those forms in a timely manner. So make sure you automate that. Make sure you have a process in place so that someone's doing that for you really quickly so you can do the signature and get that out the door really quickly. Budapest. Anyone know the guy in the middle? That's Kitchens, right? He's a great guy. He's traveled the world, this guy. And then on the far side, that's Drew Somerville, one of the former fellows here. He's now up in Indiana, just doing fantastic. And Budapest. All right, so this is a Dr. Sanders thing. This is probably one of the best things I learned at UK. The little box detailing the patient's name. We used to be on paper here, and it was the best because Sanders always had great notes, and she would have a little box, and she would have some little note about the patient, the dog's name, the daughter's name, where they're going on the next trip, and that was absolutely crucial. Can you still do that in EMR? You still do it? Sticky notes. All right, good. And you still do it? Okay, all right, yeah. But it's great because in a busy clinic, I saw 84 patients yesterday by myself. I don't have residents, I don't have fellows. You have to bring a personal touch. You have to make that 5 minutes count. And so if you have that little box detailing the patient's life, something that shows a personal touch, and you actually do remember that, internalize it. You just need a little box to remind yourself sometimes. So this is Caroline Bummel, Dilshire Dewitt in downtown Manhattan. I've given several talks in front of Wall Street before, in front of a crowd of investors, which is very interesting because they ask very, 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 very detailed questions. I've also given talks in front of 0 people before. I've flown to Miami for big talks before and no one shows up. I've given talks in Idaho in front of 2 people, and I've given talks in front of 1,000 people in the Middle East. So it's a variable audience you can talk to over time. There's lots of opportunities out there if you give yourself the opportunity to speak. Monitor your online review. So this is a really key one. So I get probably 2 to 3 patients a day who come in to see me because my online reviews. I didn't do anything to get that patient in my door. They looked me up online. And do you know what the number one thing we're judged with online is? There's actually two things. There's actually 2 things you're really judged with. It's not quality. There's 2 things you're judged with. Number one, by far, waiting times. That's by far number one, waiting times, because people can judge waiting times. And it's frustrating because they'll show up half an hour early to clinic, 45 minutes early to clinic, but to them, they've been there. And so you have to take that into account. So people judge waiting times. The second thing they actually judge, insurance, right? And you have no control over that. There's a ton of online reviews about, Dr. Stunt, not me, but like Dr. Johnson, Dr. whoever has is horrible doctor because he doesn't take my insurance. Well, not really my fault. I'm not contracted with your insurance, but just know you have to monitor those things, and you have to kind of correct people, or you have to make sure you get those reviews off, because people really look at those online reviews. And I have old patients. I can't imagine how it would be for cornea refractive, for anything besides retina. Retina, my patients A, can't see that much, and then B, they're all old, but still they come in with online reviews. So gave a talk in Dublin, and so Timothy gave me all the places to go, including Peter's Pub, which is great. I think that is my final one. So here they are again. Just record and watch your surgeries. Scrub with your partner, especially at first. Publish, present one project a year. Keep in contact with your mentors. Really watch those reps. I'm telling you, they're vectors of good and bad information. If you have a complication, make sure you communicate with that patient. I don't love email, and the reason I don't love email because it's time and date stamped a lot. I would give cell phone, because two things: it's actually harder for a patient to pick up a phone and call, and the second thing is it's not so time and date stamped, and it's just, I don't know, somehow patients don't really call you that much, but if you give them an email, they'll sometimes kill you with emails. Remember everyone's name. That's a key crucial thing, and I need to get better at it. If you don't remember everyone's name, an easy way to do it is tell your manager to get a book together with everyone's faces, right? Because it's really hard after you've been working next to Sally for 2 years to be like, Sally, what's your name? But if your manager will go through your staff, whether it's a surgery center, whether it's your office, and put everyone's name together with their face, then they give you a book, then it's actually very easy for you to memorize it at night, right? Home gym and healthy lunches. We talked about booking cases for more than 150% of the time that you expect it. Maid service is crucial. Automate your life as much as possible. I have every single day probably about 1,000 decisions to make, right? 1,000. And probably 200 of them are actually high level, 800 of which are just kind of routine, mundane. The more I can put those 800 on other people that I trust, the more I can concentrate on the 200 that actually makes a difference, because we are all products of our decision. Our patient care is products of our decision. So make sure you automate the stuff that really doesn't matter. The little box, I'm telling you, that is so crucial to remember those patients and their lives matter. And then finally, monitor your online reviews. That's a critical part. And if you don't have time for it, then make sure you have someone that's doing it in your practice, because you'd be surprised, 1 or 2 bad reviews can really kind of hamper your building a clinical practice. And with that, thank you guys so much for being a great audience. So thank you very much.
Okay, thank you again, Dr. Stanley, for those 2 talks and for coming by. Okay, so that concludes our resident day. We're gonna have lunch. I think lunch is actually set up already, right? Okay.
You can follow Shelby, she'll be directing everybody, so it is downstairs, it's not too far away, so there is an elevator and some stairs, so it all leads to the same place, so just follow this girl's line.
There we go. Yes, so go for lunch.
Sorry. Also, if you're a resident, please stay behind for some pictures. Thank you.
If you're attending, go out in the lobby, we're gonna go for a minute.
Time to cry.
Present, well.
At the end of the thing.
Here, let me